Ok, olá, boa tarde a todos. Bem-vindos a mais uma sessão APAH TALKs, desta que é a nossa 8ª Conferência de Valor da APAH. Este ano, e fruto da pandemia, construímos um conjunto de sessões dedicadas à liderança e à inovação na INCERTEZA, trazendo temas a debate que nos ajudarão a gerir a mudança para o futuro. Esta conferência é, acima de tudo, uma plataforma ou um meio de partilha de boas práticas e a sessão que agora iniciamos é mais uma excelente oportunidade. O meu nome é Catarina Batista, sou vogal da direção da APAH e queria, antes de apresentar o orador convidado de hoje, introduzir o tema do valor em saúde. Todos nós, enquanto profissionais de saúde, quer na área da gestão, quer na área assistencial, já absorvemos este conceito, sabemos o que significa, mas também temos a certeza que não o adotamos a 100% na nossa prática cotidiana. A gestão de saúde baseada no desenho e na identificação da cadeia de valor e de cuidados está suportada em critérios de eficácia, de eficiência e de equidade. E eu aqui estou a parafrasear o Dr. Francisco Ramos no prefácio do livro que foi editado e lançado nesta segunda-feira pela APAH, que convido a todos para consultarem, vai estar à venda brevemente e é o primeiro livro português dedicado ao tema valor em saúde. So, without further ado, I would like to introduce our speaker for this session and encourage everyone in the audience to ask questions. You can use the platform of the conference to do so, but you can also pose the questions online on the Facebook. On the platform, you have on the top left corner a button for colocar questão. So I will manage the questions during the lecture. So, Peter, welcome to our conference. Let me thank you in the name of the Portuguese Association of Hospital Managers for accepting our invitation. It's truly an honor to have you here. Pieter De Bey is the Managing Director of the SANTEON Hospital Group in the Netherlands. He is responsible for executing the SANTEON strategy via shared programs across the 7 hospitals of the group. He is also passionate about value-based healthcare, which is the guiding principles of the SANTEON Hospital Group. Prior to SANTEON, Peter has worked as a principal in the New York City and Amsterdam offices of the Boston Consulting Group, and he was also the VP of Operations at ISHOM. Peter, it's a great honor, as I said, and a privilege to have you share your experience in this subject. I'm sure we will all be enriched after your talk on leading a value healthcare culture. Peter, you have the word. Thank you.
Obrigado. Thank you very much for having me during your conference. And congratulations on the book that you just showed. I think that's wonderful that you have this book. I will start sharing my screen so I can... So what I will talk about is our approach, the SANTEON approach to value-based healthcare. And what I will start doing is just give you a brief introduction of SANTEON. I'll talk about the approach to value-based healthcare. I will give you some concrete examples because I think that's the best way to probably explain what our approach exactly is. And then I'll share some lessons learned. And please indeed ask questions, clarifying questions, or also clarifying questions during my talk, or at the end questions when you would like to discuss something, or we can go further in depth. So
Okay.
Feel free to do that. So what is SANTEON? So SANTEON is a Dutch hospital group of 7 hospitals, and I call it a learning system. So basically what we are is 7 acute and chronic care hospitals with a national coverage around the country. I'm currently based in Amsterdam, which is the location of the OLVG, so that's the upper left hospital. But the others are, as you can see, spread across the country. We basically form a network of those 7 hospitals, and our key point is that we try to learn and develop as much as possible. So together we are the largest provider of hospital services in the country, with about 11% of national volume in hospital care, about 3 billion euros in revenue, 35,000 employees, of which about 10,000 nurses. And I think these numbers are mainly important to show you that the improvements that we are able to make across our hospitals and for our patient population really can have an impact because of the size of the hospitals together. We defined 5 key ambitions already a number of years ago when starting in this collaboration. And the number one, I think, is also probably the most important one. It is that patients are actively involved in their treatment choices. So we try to work on shared decision making. So more and more have patients be together with their doctors decide what is the best treatment option. We stimulate our professionals to work closely together, really in the network of the 7 hospitals. We share the research capacity and also the patient volume to innovate, to scale up innovation and to do research together. We find it really important to make our quality of care transparent. So first of all, to measure quality of care, and I'll talk more about that. It's really about measuring outcomes, but also to work on how to make this more transparent towards our patients, towards our like the GPs who can refer patients to our hospitals, but also for the health insurance companies. And we feel an obligation to make care affordable and keep it accessible. So we also work on the cost side of value-based healthcare. So value-based healthcare, I talked about it already a little bit, and I'm sure that it was mentioned earlier in your conference. It is our guiding principle. So we define it as patient values health outcomes over costs, which is the formula that was defined by Porter and Thijsberg in their book in 2005. And we really, in our improvement cycles. And I think the improvement cycle is sort of the core of what we do at SANTEON. So we run a standardized improvement cycle across the 7 hospitals, where we always start with defining a multidisciplinary team and the process in which the team will work together and how they will share data, etc. Then we set up, and then we start your sort of typical PDCA cycle. So it's about collecting data, analyzing the data, looking for differences, then analyzing those differences and identifying improvements, and then implementing those improvements. It's a continuous feedback and learning system. And I think what is quite important is a couple of things. One is that we do it in a strict cadence, which means that one of those cycles takes around the patient group and not a medical procedure. So it's not about a certain intervention, a certain surgical intervention, or it's also not around a specific specialty like internal medicine or something. It is really around the patient group and the entire patient pathway. And we aim for full transparency on patient outcomes, costs, and processes. And this is basically what that looks like. So within each of the 7 hospitals, you see it in the map on the right, in each of the 7 hospitals, we run this improvement cycle, but we also run it as a group, as a whole. So, and the central one, the central cycle is the one that takes 6 months. Within each of the hospitals, it can go a little bit faster, and there's a number of meetings in between. And we have now set this up. We started this approach back in 2016, and now in the last 4 years, we scaled it up to 15 conditions, and that's where we are now. You see, these are a number of the large oncological conditions: breast cancer, prostate cancer, lung cancer, colorectal cancer. Then there's a number of orthopedic focused conditions: hip osteoarthritis, knee osteoarthritis, hip fracture, a number of chronic medical conditions, and also the latest addition, and that's an improvement cycle that we started only this summer, is the COVID-19 cycle that we started after the outbreak that we are all battling with, both in Portugal, as I'm sure, but also in the Netherlands, where the numbers are going up very fast right now. So we are definitely in the middle of our second wave, and we try to learn as much as possible from the first wave. Also, obviously from international studies and from scientific research, but also by using our improvement cycle methodology, where we share across the hospitals best practices and data. So So how does it exactly work? So for each of the conditions, and this is an example for the breast cancer group, we define we bring together a multidisciplinary improvement team in each hospital, including patients. So for example, for breast cancer, in those teams, there's a surgeon, a pathologist, a radiotherapist, an oncologist, plastic surgeon, nurse practitioner, radiologist, clinical nurse, and a pharmacist. And in some hospitals, there might be some other roles in there as well, but at least it should be a multidisciplinary team. So it's not just the breast cancer surgeon, but it's really a whole team that is working on this patient group. And it is supported by a project leader and by data manager and analyst. And we always try to involve 1 or 2 patients to really have patient participation, because what we see is that when patients are part of this conversation and part of the improvement cycle, it really changes the focus and it changes the conversation to really focus on what matters most to patients. So I think patient participation and patient activation is a really important point here in the way that we approach the improvement cycle. So what is value-based healthcare for us? I think what it becomes more and more is that it is basically data-driven and patient-centered care. And data-driven, I mean, obviously, the way that we provide care in modern hospitals is always data-driven, right? There's a lot of diagnostics being done, there's lab results, there's a lot of data. But typically the data is mostly used for the individual patient. And what we try to do is also bring the data together to use it at an aggregated level to learn and to continuously improve the patient pathway, and do that in a very patient-centered way. And then also bring back the data that we get from this aggregation and the analysis and bring it back again to the conversation between the doctor and the patient. So it's a slightly different loop than I think we typically see in a hospital setting using data. And I think an important lesson that we learned over the last couple of years is that the improvement teams, so those multidisciplinary improvement teams, they go through different stages of transparency. I told you before that transparency for us is important. So we really try to share both internally and externally what we learn from the data. And how this works is that the blue stage here on the left, which is the first stage of transparency, we call it internal transparency. It means that we bring together those multidisciplinary teams. We have them look at their data. So we provide them with the data, outcomes, costs, and processes around the patient group. And then we try to create a trusted environment to have open discussions and an open learning culture, not just within the hospital, but also across the 7 hospitals. So internal transparency for us means that you're open about your data, willing to share it across the 7 hospitals and talk about your best practices and also worst practices potentially. So it's about creating this trusted environment, getting to reliable data, because typically what we see is that the first couple of cycles, the first times that you look at this data, there's a lot wrong with it. And that's also a critique that often our medical specialists and nurses, give the teams, the supporting teams, like this data is crap. It's not reliable. Our patients are very different. We have a very different case mix. There's a lot of stuff wrong with the data typically. And sometimes that's true. And sometimes it's less true. But often there's a lot to improve. So you need some time in the blue phase here to get to reliable data and this trusted environment, and then maybe implement already some obvious improvement opportunities. And this blue period typically takes about 1.5 years. One cycle for us, remember, it takes 6 months. So about 3 cycles is about 1.5 years. Then we move from the blue to the orange to the middle phase. And that we call external transparency. And that means that we also want to publish the findings, publish the data, but also publish the best practices, the learnings, and bring it, publish it on our own website, but also publish it perhaps in a journal. And that means that the results become available for everyone. It's a possibility to deepen the analysis and take more sophisticated actions, and also work on topics like shared decision-making. So discuss those expected outcomes with patients. So that's the second phase. And then we try to get to the third phase, and there's few of our medical conditions now getting in this phase. So we're actively working on the purple one on the right. And that means that we try to define a standard of care or a standard of practice sometimes, but also really a standard of care. So around what do we actually believe is our good results for our patients and also define it together with our patients. It means that the method needs to be fully embedded. The continuous improvement cycle needs to become part of the organization. We have a focus on innovation and research. And also we try to get to value-based contracts with our insurance companies. So here you see that sort of typically these improvement teams go through these different stages. And I think this is quite an important finding for us. And it also is good to make this, to kind of manage expectations up front. And also to tell them, you know, there's time to stay in the blue phase. There's time in the beginning to get used and accustomed to the information, to the data, to this new way of working. Mm-hmm. So I think this is an important message. So a little bit more about outcome transparency. So we started already back in 2013 with our first publications, where we become transparent about outcomes, about the quality that we provide. And here you see a number of examples on breast cancer care, on stroke patients, and on hip osteoarthritis patients. Then in the middle, we started, and that's only in 2019, so only about a year ago, we started building infographics and publish them on our websites as well. Both the SANTEON website is a central website, but also the websites of the individual hospitals. And again, a different way of being transparent about our results, informing patients about different treatment options, for example, available for them, and what expected outcomes could be. And then the next thing that we're working on the right is really also turning this information into decision support instruments that can be used in the conversation, in the clinical setting, in the conversation between doctors and patients, and have them, you know, sort of the patients like me approach, where we try to identify similar groups of patients and see what the results of the treatment options typically are, and have this openly discussed again in the setting between doctors and patients. So so this is our approach, and I hope it kind of clarifies what we do in the improvement cycle. But I think I can make it more clear by giving you some examples. So the first example that I came with is on our breast cancer team, from our breast cancer team. And here you see the standardized scorecard for breast cancer. So for each of the 15 medical conditions, we build a scorecard just like this one, where there's always 3 things on there. There's outcomes, there's costs, and there's processes. And the outcomes are things like 5-year survival, the reoperation rate due to positive margins, but also PROMs, quality of life, pain, functioning, specific conditions. And what we try to do is, when defining those outcomes, we try to stay as closely as possible to the ICHOM standard set that is available publicly by ICHOM. Then we have a number of cost indicators, and the costs, I call it costs, but we typically don't necessarily define it in euros. So typically we look at more the use of resources. So this is the average length of stay, for example. This is the number of days a patient stays in the hospital. And also the operating time, for example, per patient, or the number of outpatient visits, or the diagnostic activities, typically the average number of MRIs or PET CTs or CT scans per patient, and also the use of expensive medication. So these are the core parts, key cost drivers, basically, for along the patient pathway. And then some processes, and here you see examples like the number of days for referral to the treatment plan, or the percentage of patients actively informed about the consequences of treatment. And especially these first ones around the number of days something takes is typically something that we hear from patients is super important for them. So I was in a meeting already a couple of years ago where there was a breast cancer patient in the room, and she said, you know, I found the 2 weeks that it took for me between referral from my GP from a family doctor to the hospital, and then getting my treatment plan. It took about 2 weeks in her case, and she said that was the worst part of the whole, experience. It was way worse even than the chemotherapy, and this is typically something that we don't measure. At least we didn't at that time. So we started measuring the time it takes from referral to treatment plan and try to shorten it. And what we saw was that there were large differences between hospitals. So I think these are typically things that only when you bring patients into the room that you really understand what are these most important factors that we should work on, KPIs. So when we look at the data, what we see is that typically for something like 5-year survival rates in breast cancer, we only see small differences. And I think that's what we expect, because we are, I would say that all our hospitals are very high quality hospitals. They work with the newest guidelines, protocols. So you wouldn't expect big differences there. And it would probably be similar in Portugal, I would expect. So you don't see big differences in these outcomes. However, for example, on the cost side, what we did see was that there were quite large ranges in diagnostic costs. It's here in dollars because of this is an English presentation, but between $400 and $900 per patient in diagnostic costs, and in certain medication costs, $2,000 to $5,000 per patient. So that's quite a big difference, especially if you multiply this by the number of patients that we treat, which runs in the thousands. And other outcomes than survival, we did see differences. For example, the reoperation rates after a positive margin, so there's still tumor tissue left after the surgery, it actually ranged between 3 and 11%, which is quite a big difference, we thought. And I'll talk a little bit more about that. And here you see that, the 3 to 11%. So here you see that there are 6 hospitals here on the left, and then the average on top is the SANTEON average. And the red bar was the initial cycle, the first time that we measured these results. And then the black bar is a year later, after doing the first improvement round. And I just mentioned the 3 to 11%, and here you see that the CWZ, so the third one on the list, was the one that had 11% positive margin. And the Martini Hospital, which is one of the other ones, had only 3%. And so they started to learn from each other. And one of the things that CWZ saw was that there was a difference in the technical approach. So they started using an ultrasound during the operation if the tumor was visible, and they adopted that from one of the other SANTEON hospitals. They also worked on awareness. So now they were aware, every member of the team became aware that there were higher reoperation rates in their specific hospital. And they just had a more focus on this topic, and it became part of the multidisciplinary team discussions. And then also we found out that there was a standardization issue. So there were differences in the interpretation of those margins by the pathologists across the hospitals. And I think this is typically what you see. So you see multiple causes that is hard to sort of come up with immediately, but with additional research, you can find these things. And what we also see is that it is possible in a very short amount of time. So here you see CWZ was at 11%, and then about a year and a half later, they were at 4%. So they were able to really bring back, really improve quality of care they were able to provide. So this is just one example. We have many, many of those examples. But this is where you see that can be really powerful to measure, analyze, and learn from each other in a very short cycle. Here's a second example, and this is on hip osteoarthritis. So again, you see sort of the same scorecard. You see outcomes, costs, and some processes. Over 9,000 patients were included at this point. And again, you see some PROMs, the patient-reported outcomes, or quality of life, pain, functional status. What we saw here was that there were very few complications during hospital admission, basically across the board. So again, that was sort of a good outcome. We didn't see any surprises there. We saw that about 98% have not undergone a revision surgery within 2 years. But it was important to get to more transparency about those revisions to figure out what those 2% in particular cases were. So we started digging deeper there. And we also achieved a decrease of 17% on the average hospital length of stay after a primary total hip operation. I'll show you a graph about that later. And I think quite interesting as well, quite different practices and communications towards patients, and about what they could and could not do during the recovery phase. And what we found out, there were actually some of our hospitals who were still providing information to their patients that was very outdated. So there was newer literature available that said that patients didn't need to take rest, for example, for a long period of time. They could actually become active much sooner. And that is something that was just not updated for a long time. So they were able to, by learning from each other, they could reduce the number of lifestyle rules for their active patients a lot, which actually had quite a large impact on the patients as well. These again are some examples, and here you see how we were able to reduce the length of stay And what you see here is on the x-axis, you see the number of admission days. So 2 days, 3 days, 4 days, 5 days, and how we were able, again, in about a year time to bring it down. On average by 17%, even especially the hospital stays that were longer than 4 days, we were able to reduce the number of patients that had these long stays by almost a quarter, 23%. And those improvements were, you know, sometimes relatively simple things, but like more hospital admissions on the day of operation, so not the day before, but also implementation of, which is more complicated, a rapid recovery program with a lot of dimensions, but where we could, again, learn from each other how to implement a rapid recovery program, which had a real impact on the average length of stay in the hospital, and therefore obviously on costs, but also from a quality perspective. I mean, you don't want patients to stay too long in the hospital. It's much better for them to go home, if obviously home setting is right for them. Let me go to a third example. So as I mentioned earlier, we also started a COVID-19 improvement cycle this summer. So what we did there was the same thing that I just talked about earlier. So in each of our hospitals, we brought together a multidisciplinary team, in this case consisting of intensive medicine doctor, intensive care nurses, lung doctors, pulmonologists, nurses from the clinic, infectiologists, I'm not sure what the English word is, but sort of bring together the whole, again, multidisciplinary team with all the different disciplines, and have them look at the data again and come up with different themes that I thought there's room for improvement, or at least room to learn from each other. And these are the 7 themes that they came up with. Part of them were more from a nursing perspective, and some of them a bit more from a medical specialist perspective. And I can just briefly talk about these themes because it shows you, I mean, obviously we're not done with this yet, right? I mean, we're just in the middle of the second wave, but what we saw there was that there's a prediction model. So they started building a prediction model on the value of doing a CT scan, for example, for ICU admission. And they're currently busy collecting data to validate the model that was built in one of the hospitals across the other 7. They started working on the physical and mental stress of the staff. And again, there was an analysis done in one hospital, and we're now expanding it to the other. There's a specific focus on nursing care, so comparing results on, for example, decubitus, when patients were placed on their stomach during ventilation. This turned out to be a problem, and there's different ways to deal with that. Also working on line sepsis, nutrition, nurse care pathways. There's a focus on complications. You know, what are the short and the long-term complications for these patients, which again are the outcomes for COVID patients. And for 2 of our hospitals, we now have the data set complete, and we're now completing it with the other hospitals as well. We also started at the same time working with ICHOM to develop a outcome standard set in the way that ICHOM is used to doing that. We initiated it together with ICHOM to make sure that there would be a global standard available, and I will show it in a minute, a global standard available for this particular patient group, so that we can all focus on the outcomes that are most important to our patients. And part of those outcomes are the complications. That became one of our themes here. Then there was a group that started focusing on the after treatment, the COVID-19 care path after the patient left the hospital, and also measuring PROMs, so the patient-reported outcomes. And what we noticed was that basically all hospitals have implemented different care paths. So we're now investigating the differences, whether, for example, home monitoring, which some of the hospitals started doing by using connected devices, whether that actually had an impact on length of stay or on the number of patients that needed a readmission to the hospital, and also doing interviews with patients. Again, obviously, preparation for a second wave. Well, we're now in the middle of that, but there we started, exchanging plans across the hospitals and learning from each other. And then we also looked at the cost side. So what are actually the costs of treating a COVID patient, and are there sort of different ways of organizing this to become more cost efficient? Again, quite often it is driven by things like length of stay or the use of expensive medication, or obviously the ICU stay, because that's obviously a very expensive part of the treatment. So we developed a dashboard where we can monitor the variation and are now trying to set it up in a way that we keep it updated also during the second wave. And I think what is nice to show you here is, and that is something that is publicly available, if you go to the website, ICHOM's website, www.ichom.org, you can look at this standard set. And this is the set of outcomes that were developed by a global team. And it's not super visible, but on the bottom right, you see a map of the world, and you see all these dots there. So you see also from Portugal and from Spain and from the UK, the Netherlands, all across Europe, also Asia, United States, Canada, South America. So there were people involved in a working group across the globe to get to this standard set on the left, where you partly see topics like survival and the disease severity, but also functional status, social functioning, and mental functioning. So kind of all the elements that are really defined as the most important outcomes from a patient perspective. So I would advise you to have a look at this and see whether, for your own COVID patients, whether you could measure some of those results and see whether whether you have enough focus on all of those elements that matter really a lot to patients. I think some findings from us so far, but we're still working on this, is that what we saw, we have some observations, and again, this might already have changed by now in the second wave, but what we saw in the first one was that the line sepsis was 5 times higher than average for an ICU patient. So about 14 to 17 out of 1,000 catheter days instead of 3. And we don't really know yet why, so this is something that we're looking into. We also saw variation in pulmonary co-infection, a variation in the number of tube changes that was necessary in the ICU, and also variation in length of stay across the hospitals on the ICU, which is partly defined obviously by case mix, the complexity of the patients, but also by other factors that we're looking into, and partly treatment differences in the way that the treatment was set up. So I think this is kind of the update that I can give about the COVID part for now. We can obviously talk about it later, and I'm very curious whether some of you might have observations from your own experiences that might be helpful also for our improvement cycle.
Yeah.
And here you see some of the variation in length of stay, for example, on the top left, the 7 hospitals, and you see that some have an average length of stay around 7 or 8 days, but others are more around 15 days. And we're still figuring out what actually sort of explains that variation. And what you also see on the top right in the blue graph is that the average admission duration over time has declined, which I think we see across the globe. So we see that the average length of stay, by improving more understanding of the virus and more understanding of the treatment options, we see that the average length of stay reduces. Nowadays, most patients are discharged within 5 days, is typically what we see, which obviously has a big impact on the capacity that we need to in the hospitals to be able to treat those patients. Example 4 that I brought, I have 5 in total, so I'm almost at the end of my presentation, is that we also are working on value-based contracting with health insurance companies. So we explore different types of contracting in the Netherlands, and I think it's similar in my discussion sort of with the team preparing for this conversation. We talked a little bit about this, and I think there's a lot of similarities in the way that in Portugal and in the Netherlands, we are reimbursed by our health plans, which is mostly fee for service, right? So we're basically paid for production, and that is in the Netherlands also the case. So the more we do, the more we are paid basically. So there's a real focus on production, incentive for production. And we have a DRG system that is basically a mini bundle, and that helps a little bit. So the bundle, it basically means that if we, for example, reduce length of stay in the hospital, that actually improves our bottom line impact. That has a positive impact on our profitability, because that's a cost that we directly incur ourselves. It's not like if a patient stays 1 day longer, we get more money. No, we get the same amount even if the patient stays shorter in the hospital. So that's a good thing. But some of the other improvements that we typically see in the improvement cycles is not something that you get actual financial results from. Because, for example, if you choose more conservative treatment, right? If you don't do a surgery but go for a more conservative treatment, well, typically you get less paid for that. Or sometimes if you change towards a video conference a consult instead of a physical one, it might result in lower income, lower revenue. So we're trying to change that and to take out those sort of wrong incentives that are in the system. And for our breast cancer, I think we have the best example is for our breast cancer team. There we were able to get to different value-based transparent agreements with health insurers. And one was based on a performance bonus. So when we could show that we actually improved our outcomes over time, we got an improvement. We got basically a financial incentive, a bonus based on that. And another example was that we set up a bundled payment contract for our breast cancer patients, which means that we basically get a one price, one rate for the entire treatment, which gave us the incentive to improve and to become more efficient within the same pathway, while not losing our income, and basically have a shared savings set up. And I think that it helps, but we also found is that it's really hard. It turned out to be quite difficult, and we had this first breast cancer contract already a few years ago. We've tried to replicate it for many of our other medical conditions, but it turns out to be quite complicated to get to the right contract, to get to the right bundles definition, to get to those performance set up in a way that it really helps to drive improvement, because that's in the end what we want to achieve. So we're still figuring this out. I think we have a few good examples, but this is something that it's still early days for us as well. And I think the last example that I would like to provide you with is the focus, the transition that we're making now from using the data that we collect and the outcome information on an aggregated level to improve the patient pathway towards also outcome transparency for shared decision-making. And we started a program about 2 years ago now, and we got a subsidy for that, where we provide insight into the value of transparency of patient-relevant outcomes and identify best practices to disclose those outcomes and to use these outcomes for shared decision-making. We have basically 4 concrete aims. We call it an experiment because we're still figuring out how to do it, but we are actually building real products. The first aim is to use the real-world outcome data to extract new and valuable insights from the data. Then we develop and implement an effective approach to use it in shared decision-making, where we also inform patients about outcomes they can expect at different care providers to have them make better decisions to what hospital should I actually go with my particular sort of demands and wishes and wants, right? To really understand what is important for this particular patient, also in a journey towards more personalized healthcare. And then the fourth one is gain insight into the degree to which shared decision-making in the end leads to different choices and or increased patient satisfaction. So there's also a scientific research study underlying this with 3 different promovendi working on this. And here you see some of the tools that we're developing that can actually be used, again, in the conversation between doctor and patient. So I think this was my 5th example, and I would like to round up by showing you some of the lessons that we learned sort of along the journey that we've been going through over the last number of years. So I think that, first of all, it's really important, sort of for me, at the core of value-based healthcare is to create a common understanding of value. And I think ICHOM, again, helps with that, because they provide you with a set of outcomes that you can use that are really defined from a patient perspective. But I think what you need also along your clinicians, along your nurses, but also along management and the administration, to create a common understanding of what do we mean when we talk about value, patient outcomes. And then ensure long-term C-suite commitment. So I think what we need for this is that the board of directors is really behind investing in this. And then start small. So we did that as well. So we started years ago with a focus on 3 conditions in a pilot setting, but now we've scaled it up to 15 conditions across 7 hospitals, which means that we have over 100 of those improvement teams working on this now, which involves over 500 people, medical professionals that are working on this. So it's quite scalable right now. It's sized up quite a lot. But start small, be pragmatic, and then create this snowball effect. I think another lesson is that you need to build a safe learning environment. You know, when you want to openly discuss those outcomes and learn from each other, you shouldn't judge. So this is not about judgment, but it's about learning. And also keep a pace towards transparency, because it's quite easy to say, you know, I'm willing to look at my data, but I will not share it. I will keep it by myself. And I truly believe that it's important to work towards transparency, because that will open up the opportunity to also compare internationally, for example, or with other providers. And we obviously do this already within the network of those 7 hospitals, which is also a good way, because it also creates a little bit of competition. And that is also good, right? It's sort of nobody wants to show, you know, wants to rank basically bottom. And I think what we see in general is that it's typically the case that the one hospital, you know, achieves great outcomes on the one end and the other one on a different KPI. And by bringing that together, we can sort of improve together. Then have medical professionals take the lead. So don't have, you know, administration or managers take the lead, but really have medical professionals take the lead, but do provide them with the right level of support. So they need to be supported. Many of our team meetings are at night. You know, it could be the surgeons after a long day of surgery, and they are willing to do this because they're intrinsically motivated to actually look at this data. It's very motivating. It's really stimulating to be part of those meetings, but it needs to be sure that it's well supported by project leader, by data analyst. I think the 5th one is it is about the patient, but also with the patient. So really try to have patients participate in this. It does change the conversation. It makes it more powerful, more effective. I think the 6th one, and I added it only quite recently, but it's kind of an observation. I think it's the case in healthcare is often that there's a not invented here syndrome. So something is invented in one place, either in the industry or in a hospital, but then it's not shared with others because it is shared, but the others won't adopt it because it's not invented here, right? And I think we are really trying actively to get rid of that. So I think there's so much already great work being done around the world. So what we try to do is copy as much as possible from others. I think it's actually quite a good sort of strategy. And obviously we also, you know, innovate ourselves a little bit and we do research, etc. But I think the most powerful thing is to be willing to learn from best practices from others. So I think that learning culture. I started this presentation with the learning system, learning culture. I think that is a core element here. And then my last point is it is hard work. It happens one step at a time, but we really believe that it's definitely worth it to take an approach like this. So I hope that I've been able to kind of take you through the SANTEON approach to value-based healthcare, share some of our findings and insights, and well, hopefully you have some reflections on this or maybe some questions. So I think I'll give it back to you here.
Yeah. Thank you, Pieter. It was an excellent lecture, and it was very clear, and you went straight to the point. So thank you so much for your lecture. We have a few questions here, yes, but I would like to just pick on the last message that you told that. I agree with you. So we don't have to be constantly reinventing the wheel. So we have to build on continuous learning and this continuous improvement process. And that was exactly what you showed here today. So thank you. You pinpointed the basics of the roadmap on how to implement value-based healthcare. You talked about the relations that needs to be assured between the patients, the results, and the funding. And let me just look at the questions that we have from our audience. One question here, it's a broad question. So what learning tips can you share with us to assure the adoption of a value-based healthcare? Your last slide sort of resumes it, but...
I think one thing that I did mention, I think, but that is important, is that this will take time. And I think that is, you know, so I said, you know, start small and then create a snowball effect, right? I think it's also sort of, in the end, it is what we try to achieve is also a culture change, right? It's about learning to work for our medical professionals, learning to work with data in a different way, become a more data-driven organization, data-driven decision-making. And that is kind of a new skill set. And it needs time. People need time to get adjusted to that and to get acquainted with it, basically. And I think that is fine. And I think it is important to also in expectation management, as I call it, you can't expect results from an approach like this, for example, within 6 months. Yeah. So I think it is important to take some time to get this started. And what we see in reality is that actually we do see results quite quickly. You know, we do. I gave you some examples during my presentation of improvements in infection rates or in length of stay reduction. So that's actually cost saving already within a year time. So in the end, it actually does go quite quickly, but I don't think you achieve it by demanding results initially. I think you need to give the professionals time to lead this approach, to get used to it, to find the right way of doing it from their background, but then you will see results. So I think that's an important one as well. So expectation management a little bit.
Yeah, of course. And also these kind of, these projects need to be built on a very consistent data information system. I don't know where did you started? So you started to construct that first and then build the data-driven care?
No.
Or how was in your process in SANTEON experience? Because you are talking about 7 hospitals in the same group. Do you all share the same information system? Do you all
no, we don't.
Data?
No, we have different. I mean, each of the hospitals have a electronic medical records and EMR, but they're not the same ones. So we don't share one IT system. We don't have one data platform. We are building one right now, but that is because we are at a scale where we need to kind of professionalize in the data information. So we're building a shared data platform right now. But we did not have that when we started. And I don't think you need it. I think what you need in the beginning is the right mindset. Yeah. People, data analysts, what we just said is, it's really that simple, right? We came up with this scorecard that I showed you for breast cancer, for example. Mm-hmm. There are just 10 things on the scorecard, and we asked a data analyst in each of the hospitals, just go and find a way to get this information together, right? To find this information for a well-defined patient group. Just, whatever you need to do, just grab it from the systems in one way or the other. Yeah. And we've actually been doing it that way for quite a long time. And obviously you want to do it in a safe way, and it needs to be GDPR compliant and all that. So you need to sort of do it in that way, but you don't need a shared system from the beginning to do it. Because in the end, it is about what you do with the data, right? It's not about, and it doesn't have to be 100% perfect. Mm-hmm. So for example, what we also don't do, I think, which I didn't talk about yet, but we don't do case mix corrections, for example. So we don't adjust for the risk factors before going to a meeting. So we look at raw data as much as possible together with our clinicians. And then only when we find like, hey, this is an interesting data point, and there we should dig deeper, then we will do, things like adjustments for different cohorts of patients, or to do a risk factor, all these kind of analyses. We'll only do it once we go and choose a certain way, because it's not a scientific approach from day one. You don't need a 95 or 99% confidence level to be able to have the right conversation.
Mm-hmm. Okay.
Is that an answer to your question?
Yeah, perfectly. I acknowledge your honesty on saying that you don't have a shared system, and you don't need that to start, and that's very important. That's a very important message to leave here. So you also talked about this healthy competition that you have between the hospitals on the group. Do you so you have benchmarking inside the group, but do you also benchmark outside the group?
So we try, but it's actually not that easy, because there's not that many others that are transparent about those results. Yeah. So what we do have in the Netherlands is we have a number of good quality registries at the national scale. So we can use those registries to compare ourselves to the national average, for example, or to some other cohorts of hospitals. So that is a source that we use. We also try to look at scientific literature, for example. How do we compare? How do our outcomes compare to others? But what is currently not there, and which I would love, to start getting to existence is also more international comparisons, more international collaboration. And I think this is one of the aims, one of the goals of ICHOM already from day one. And this is why they're also developing those standard sets. But the number of organizations that are sharing their results, typically, I think at this point is quite limited yet. But I would definitely invite also, the Portuguese hospitals, if you are collecting, basically on any of those 15 sets that I showed, or the conditions that I showed earlier, I would definitely be interesting to at least to see whether there's anything to learn from each other.
Yeah,
right?
We have some good examples. We have we have some good examples in Portugal at exactly the oncology department, the breast cancer department. So 2 or 3 more questions. So I have to manage time before the next plenary session. At what extent are you ready, or have you already introduced precision medicine to your standard set? So there are several examples of pharmacogenetics where you evidence that you improve the individual outcome. So do you account for that in your standard set for the final outcomes?
So it is obviously something that is implemented in a number of our hospitals, sort of these new treatment options. It is not something that directly impacts at this moment our standard sets, because what we measure there are outcomes, and those outcomes can be improved, right, by these kind of techniques. But I think this is also the advantage of the approach that we take, is that we just measure outcomes, right? And if you change anything if you innovate, right? If you bring innovation in your hospital, in your clinical workflow, and you're able to improve outcomes based on that, we should see it in the results. And this is kind of the approach that we try to take. So we try to identify hospitals that are successful in implementing certain innovations, and then show the value of those innovations, and then scale it up to the other hospitals as well. Okay. So I don't think it directly has to impact the measuring itself, but this is obviously something that we're also still just working on and figuring out.
Yeah, okay. So you don't have a problem introducing that in your standard of care, basically.
No, because it's a good question. I think a standard of care is not about standardizing the whole process. We don't want that, because we want room for innovation, right? We want people to be able to experiment and to innovate. So what we call a standard of care is mostly based on a certain level of quality, right? So measured through outcomes, but not so much as it doesn't have to be a completely standardized care pathway, for example. That's not what we try to get to, because you would actually hold back innovation, I think, that way, and that's not what we want.
Okay. Good answer. Another question was about the bundle payment that you talked about. You referred that you mentioned that it didn't. You didn't expand that for other standard of care, other conditions. Why do you have that result? Do you feel that, in your experience, it's not a valid incentive to induce efficacy, to adopt that standard of set?
Yeah, I think it is important to get to those models. It just turns out to be complicated for us. And one of the reasons is that we deal with multiple insurance companies that have their own views on how to set up those contracts. And obviously our patient population, it doesn't matter whether they're insured with insurance company A or B, we want to treat them all the same, right? So I think that is one of the complicating factors, is that we're not dealing with one party, but we're dealing with many different parties. And then also it turns out that also our doctors find it sometimes, it's not easy to get to the best setup of a contract like that. Sort of what are the right incentives, and do you really want to have financial compensation for a better outcome, right? You don't want to introduce the wrong incentives either. So what I would like to really focus on also in the coming years is to really take away the negative incentives, right? Sort of the perverse incentives. I think that is more important than introducing new incentives. So I would really like to focus on getting rid of the wrong incentives that are currently in the system.
Okay.
And that can be through bundles, for example. So I think bundles in the end, bundle payment solutions, contracts is one way to get there. And to align outcomes and funding, right? Yeah, exactly.
Yeah.
And that you have the right the right incentive to continuously keep working on those outcomes. But it's not just measured by outcomes, right? It can also be by all the transitions that are going on in healthcare right now, the digitalization, right? Sort of home monitoring, sort of all these different pathways that are getting into place now. Quite often there's not a business, it's just too often, at least in the Netherlands, I see happening that there's not a business case for a hospital or for a doctor to actually make it happen, right? Because in the end, you won't get any more revenue or any more margin by getting there. Exactly. And obviously, still, if it's the best care, you still want to go there, but it doesn't help, right? That the system is set up that way, and I think it should help. It should be a stimulus, and too often it's not. So
one last question, Peter, and I don't know if this applies to your group, but if not, let me know. Is the SANTEON group involved or willing to initiate a project of this matter with the primary care sector?
You mean having them sort of working together with primary care doctors also as part of the patient pathway?
Exactly.
And sort of the improvement cycle. Yeah, that's a very good point. And we are trying to do that, but we haven't been going very fast at it so far. So what we would like is that in each of our multidisciplinary teams, that there would also be primary care doctors involved, but it could also be physiotherapists, for example, depending on the condition that we're talking about. And I think that is not the hardest part. The hard part for us, at least in the Netherlands, is to also bring together the data. Because we have very clear boundaries between the primary and secondary care. And it turns out to be very complicated to have a good view from the data over the entire pathway and the entire cycle of care. And we are working together with some national databases, basically, to figure out a way to get a much better view on what goes on outside of the hospital. Because I totally agree with you. Your point is, a lot of the care actually happens outside of the hospital walls, right? And a patient spends maybe, especially chronic patients, right, spends perhaps a couple of hours in the hospital a year, but 364 days a year not in the hospital. And this is kind of where a lot of the impact is created. But this is for us also still. So we're totally open. Your question was, are you open? Yes, we're very open. Yeah. But do we have the right solution already? How to do it exactly? We don't. So we're still figuring this out.
Yeah, I think it's. We need to go that way in hospitals. We need to reach to this integration and close the cycle of the patient, because exactly as you said, the patient is mostly outside the hospital. So we are on time now. So Peter, on behalf of the Portuguese Association of Hospital Managers, I thank you again for this excellent lecture and for sharing with us your knowledge and experiences on this subject. You have a vast experience, and thank you. I'm looking forward to meet you someday, probably in the Netherlands, visiting some of the hospitals in the SANTEON group.
You're most welcome, and thanks very much for having me. And I would love to visit Portugal at some point as well, again, when it's possible. Thank you.
Exactly. Thank you so much. A todos, queria agradecer, muito obrigada por terem estado connosco nesta sessão. Obrigada pelas vossas intervenções. É sem dúvida um tema atual. Todos nós devíamos estar a orientar o nosso futuro de gestão e assistencial para este objetivo. Penso que o futuro da saúde em Portugal e a APAH tem estado também muito interventiva neste tema, passa precisamente pelo valor em saúde. Passamos a seguir para o roteiro para a participação em saúde após um breve intervalo. Até já. Obrigada.